Okay, good morning everybody. What a pleasure it is to be here. I know people are gonna stream on in, especially Trouble back there. So I first want to thank Cheyenne. She has just been an amazing leader of FDRS over the past few years. And the FDRS has come so far. It was first started in 2009. So next year will be the 10th anniversary. So when people did not know about fat disorders, including healthcare providers, the Fat Disorders Research Society has been here and it's been building. And seeing all of you today really confirms that this is a really important society and that we should continue to support it. So today, I want to talk to you about fluid in fat tissue. And fluid in fat tissue is really important in lipedema and Dercum's disease. And these are my disclosures. I am on Tactile Medical Speakers Board, and they do make a lymphatic pump. I have taken an honorarium from lymphedema seminars, and I am proudly funded by the Lipedema Foundation. Woohoo! And I also am the author of a book called Lymphedema and Lipedema Nutrition Guide. I reversed that because what's more important? And three of the other authors are here, Chuck Ehrlich, Emily Eicher, and Linda Ann Kahn. So my outline, I'm going to talk about fluid flow through the small blood vessels, which I'm going to call the microvasculature, the small vessels in fat tissue. I'm also going to bring in the sympathetic nervous system and talk about how we can manipulate that using amphetamines to improve lipedema and Dercum's disease. And then I'm going to talk about a little bit about the ultrasound manifestations that we found in the tissue and how that helps us better understand these two disorders. So let's just lay a little background for lipedema and Dercum's disease. So we consider lipedema to be common. We think it affects around 10% of the female population. And we consider Dercum's disease to be rare. And until we have a gene, it's going to be difficult to tease these two apart sometimes and to get actual prevalence numbers. And prevalence studies are very, very difficult. You have to go out into large communities and count the number of people who have it and people who don't. And so that's going to take a lot of money, a lot of funding. In lipedema, women are much more affected than men. There are many, many, many more women with lipedema than men with lipedema. And in Dercum's disease, there are more women that are affected compared to men. And some of the estimates are for every 5 women, 1 man is affected, or for every 30 women, 1 man is affected. They're both painful. They both affect different areas of the body, and the one way that we can pretty reliably use to distinguish between lipedema and Dercum's disease is that the trunk is affected in Dercum's disease. And usually this is early on. So people say, I developed a lipoma when I was 7 or when I was 20. Whereas in lipedema, it tends to affect the lower body and the arms, and the trunk remains unaffected. There's microvascular disease in both. There's lymphatic disease in both. There's fluid in fat in both, and there's a risk for obesity for both. And the fat in lipedema and Dercum's disease I would like to call persistent fat. And this means that this fat remains even after extreme dieting, extreme exercises, or even bariatric surgery. And you heard it here first. So, many of you who know me well know that I sit around and think about lipedema and Dercum's disease pretty much so 24/7. Maybe more. I dream about it too. And I ask myself, why do people with lipedema and Dercum's disease have fluid in their fat? Because I think if we can get rid of the fluid, we can control the fat. And this fluid in the fat is why we recommend a bunch of tools to combat the fluid. And these include compression garments, and we have some vendors out here with compression garments. sequential pneumatic compression pumps. We have some vendors out here with pumps. We have therapists in the audience who have been highly trained in performing manual lymphatic drainage therapy, which helps many patients with lipedema and Dercum's disease. And I recommend, and I'm hoping now more therapists are recommending deeper treatment into the tissue to change the structure of the fat and make it better. And I know some of my patients and my friends are using these tools, and I've seen amazing changes when they use it on their face. Their skin gets better and their tissue gets softer. We recommend, in terms of body tools, rollers. You guys have used fascia blasters, gua sha tools, things that empower you to take care of yourself at home. We also recommend lymphagogues. These are supplements or medications that help the lymphatics pump better and get that fluid out of there. We also recommend exercise. When you move your muscles, your lymphatics pump better. And we recommend different diets, and we're not necessarily restricting food. We don't recommend restricted food diets. We recommend low-carb diets. Low-processed carbohydrate diets seem to work best for lipedema and Dercum's disease, but we need more studies on that. So a little bit more about persistent fat. We heard an amazing, empowering talk last night, and I was so impressed by that talk, and it empowered me as well. And of course, it's making me think more about lipedema and Dercum's disease. But I want you to think about the fat as more than just fat. In persistent fat, we find these really big, large fat cells, and that's a marker of a metabolically changed environment. But we also have fluid. We also have what's called hyaluronic acid. And hyaluronic acid is like a gel, and that gel holds on to the fluid. And I'm sure some of you who have lipedema and Dercum's disease, when you feel your tissue, you have super soft, gel-like tissue, which I love to palpate. That's that hyaluronic acid and fluid. But there's also collagen, and collagen is a type of fibrosis or a type of scar. And there's a particular type of collagen in fat tissue that's really important. It's called collagen type 6. And you have here today Dr. Phil Scherer, who is an expert in understanding this type of fibrosis in the tissue and how it prevents weight loss and makes this fat persistent fat. So when you think of fat, think of large fat cells, but also water, gel, and fibrosis. So if we look at the stages of lipedema, going from stage 1 to 2 to 3, you see increased fat. Right, and that's what everyone thinks. There's more fat. But there's also more water. There's also more gel or jelly. And there's also more fibrosis. So if you take anything home from this talk today, remember those 4 things in the tissue. It's not just fat. And we've shown that, at least in stage 2-3 lipedema, that there's more fluid than in stage 1. And I think if we had more people in our stage 3 group, we would have shown a significant increase in fluid in that stage over stage 2. So we know that fluid and the risk of lymphedema and the development of lymphedema worsens with stage of lipedema. And this goes out to Emily Eicher. Emily Eicher coined the term dancing fascia in lipedema. And we've been looking at the lipedema tissue by ultrasound, and I'm going to walk you through this. So on the top here is your skin, and then this is all fat, and then this is a band of fascia here. And it's supposed to be flat. It's supposed to go straight across. But you see this area here? We think that's fluid in the fat tissue. And in this little dark hole here, we think that's a vessel. And that vessel has leaked out into the fat tissue here. And that leakage is a little bit brighter than the background. Can you see that? It's a little bit brighter, and we call that, in ultrasound terminology, hyperechoic. So now when you read your ultrasound report and it says, oh, you have a hyperechoic mass, that's kind of what it looks like. If it's darker than the surrounding fat tissue, it's called hypoechoic, so less bright than the surrounding fat tissue. So we see these what we call masses in the lipedema tissue, and we think that it's fluid which is leaked out of vessels, and then the body says, what's that? it brings in immune cells, causes inflammation, and then the body starts to fill it in with scar, and we have fibrosis. And when you put your finger on it, you can feel that. And it's heavy, so it pushes down that fascia, and we put our ultrasound probe there, and it's blocking our ability to see that fascia. So this is the definition of lipedema, fluid in fat. So I'm not the only one who thinks that there's fluid in fat tissue. Back in the 80s, a French group also showed that the tiniest vessel in the body called the capillary also leaked out into the tissue. And I have a beautiful picture of that. There it is. Here's my beautiful picture right here on the left. It's on the left. And you see that little capillary in the center is surrounded by 5 fat cells, which are numbered. And you see that kind of thin layer of fluid oozing out down below it? That's a leaking capillary in lipedema. And when that happens, the body says, oh my gosh, what's that? And it sends in immune cells, which causes inflammation, and then it fills it in with scar called fibrosis. And you can see in the center panel, that's a capillary that has thick walls. The arrows are pointing to thickened walls. That's fibrosis in our smallest vessels in our body. And on the third panel is a small venule, a small vein, which I'll tell you more about. But you can see it's kind of bulbous and dilated. That's not a healthy little vein. And the walls of that vein are also thickened and fibrotic. So in the lipedema tissue, we have small vessels that are leaking and that are becoming inflamed and scarred. This is a small study that I did with Dr. Janiro Sanchez de la Torre, who's in the office, Rita Wadia, who's also a physician who's going to start her residency at the University of Arizona, and an undergraduate student named Victoria Rosas. And we looked at a small group of women who had lipedema, and you can see that there are the 3 stages on the bottom, and as you increase in stage, your body mass index increases. So women in stage 3 have a larger body mass index than stage 2, who have a larger body mass index than stage 1. And body mass index is not the best way to qualify women who have lipedema. We need to change that. But for now, I just wanted to show that, yes, we know that fat increases with stage. And this is the data, and I'm going to walk you through it. I know it's a kind of a busy slide, but when I put this data together, I became very concerned. And I became concerned because you can see as our BMI, body mass index, increases from stage 1 to stage 2, and from stage 2 to stage 3, that the systolic blood pressure goes up from stage 1 to stage 2, and from stage 2 to stage 3. And so does the diastolic blood pressure. And look at the HDL, the happy, healthy cholesterol, supposedly. It goes down from stage 1 to stage 2, and from stage 2 to stage 3. Now, interestingly, out of these 46 women, even though we have morbid obesity in that stage 3 group, there's only 1 lady who has diabetes. So we think lipedema is protective against diabetes, and I was really happy about that, like, woo, this is good. But then I looked at prediabetes. So in stage 0, or stage 1, you have 0% prediabetes. In stage 2, it's 12.5%. In stage 3, it's 30%. And if you're walking around with prediabetes, you are at risk for cardiovascular disease. So this is something that I want to change. This is my goal. When we think about cardiovascular disease in the heart, we think of the large vessels, the big aorta, the big veins or vena cava that go into the heart. And we also think of coronary arteries. But if you look at this is a real heart that they've put plastic in. Can you see all those microvessels? It's a carpet of microvessels all over the heart. This carpet of microvessels is all over your body. If your capillaries, which are part of those microvessels, are sick and leaky and fibrotic and inflamed, you're inflamed from head to toe. This is not good. This is something that we need to work to change. So I want to talk about physiology. I actually got my PhD in physiology, so I love thinking about it. And when we were in medical school, we learned about the Starling equation, and now we call it the old Starling equation. And even though it still applies to some situations, I want to show you where it was wrong. So you can see the heart. It feeds blood into large arteries, then into smaller arterioles, then into our smallest vessels, the capillaries. And then from the capillaries, they collect back together as small little venules, back up to big veins, and it all goes back up to the heart, which is true. And when blood flows out of the capillaries, it goes into the spaces between the cells and feeds them, which is true. And then it was thought that 70 to 90% of that blood got sucked back up into the little veins, and then it went back up to the heart. And that's where it's wrong. Because that means that the lymphatics are kind of like a secondary player. They only pick up about 10 to 30% of the fluid in the tissue and move it up back to the large veins near the heart. They only pick up 10 to 30% of the garbage that our cells secrete. That doesn't make any sense, does it? No. So here's the new Starling equation. So yes, blood does flow from the heart down to the capillaries, and as it goes through the capillary bed, less and less blood comes out. And 100% of that is taken up by the lymphatics, and that makes the lymphatic vessels an important player for taking out the garbage. But I also want to point out that there are a lot of hormones and metabolic mediators that act on those venules and can cause them to open up and leak fluid into the tissue. And that includes histamine. So if there's any of you who are out there that have mast cell activation disorder, you know that histamine is an important player in that, and it causes those postcapillary venules to leak fluid into the tissue. And that can actually overload the lymphatic vessels. And you're going to hear a little bit later on that mast cells increase with increases in fat tissue, but they also are more prominent in lipedema fat as well as Dercum's disease fat tissue. So looking at the capillary itself, we think fluid and nutrients flow out of the capillary, it's kind of a free-for-all, and that's not true. It's very highly regulated. And part of that high regulation comes in the form of what's called the glycocalyx. And if you participated in research with us yesterday, you learned a little bit about the glycocalyx, and we have two gentlemen, Bob Long and Hans Vink, here today, who are going to test for the glycocalyx in the smallest vessels of our body under the tongue. And the glycocalyx are like little hair fibers, and around the hair fibers is this gooey gel. So you can imagine that if you leak something out or you move something out from the capillary into that interstitial space between cells, it can't get back in because of that gel. So that's why the Starling equation is incorrect. And what's interesting is that not only do blood vessels, the small microvasculature, have this glycocalyx, but so do lymphatic vessels. So it protects those lymphatic vessels from leaking as well. So if your glycocalyx breaks down, then you can leak out and you can leak in, causing damage, inflammation, fibrosis. So in a normal flowing physiology system, capillary pressure exceeds that of the interstitial space, fluid and nutrients are regulated to move out, and the lymphatic vessels fill and pump it out. When you leak more out of your capillaries or more out of your venules, the lymphatic vessels start pumping faster. And you can keep up, so you're kind of in a pre-edema state. You don't have edema because you're working really hard. But if you spill more and more fluid out of your capillaries and your venules, and your lymphatics start to break down that glycocalyx, then you can get lymphatic insufficiency. You overload your lymphatic vessels. And this means that you might swell during the day, but you recover at night. So you have lymphedema stage 1. If those lymphatic vessels, however, become damaged and you pour more fluid into the tissue, they can no longer pump it out. Maybe you've had an infection in an area of your body, or you've had a surgery, or you've had some sort of trauma, then the lymphatic vessels can't do it anymore. And then you have edema all day long and all night long, and you're in lymphedema stage 2. Okay, so I've shown you this slide already. As you increase in lipedema stage, you get more and more fluid in the fat tissue. And what we also noticed, as you increase in lipedema stage, more and more of those women have hypermobility. They have increased flexibility of their joints. There's something different about the connective tissue. And blood vessels and lymphatics are made up of connective tissue. So could hypermobility in the joints be a marker for a change in the connective tissue of our microvasculature? So in my mind, and I'm going to make this very simple and it's not, but there are 3 ways to increase fluid in tissue. 1, you have increased microvessel leak. 2, you have reduced lymphatic function. And 3, the new concept, you have increased compliance to your tissue. And that's what hypermobility is. It allows tissue to bend in ways that it never did before. Fluid collects in the tissue, definition of lymphedema. You develop inflammation followed by fibrosis. So what is compliance of fat? And I really want to drive this home. This is another take-home point I'd like you to remember. If you have compliant fat tissue, you have low elasticity. You're not elastic. You're not like a rubber band. A rubber band retracts back. And compliant tissue is not stiff. If it were stiff, it would push things out, but it doesn't. It allows abundant fat to grow. It's expandable. The skin can stretch out of shape, and it can hold on to fluid. So that interstitial organ that you heard about and saw all over Facebook is large. And I think that pretty well defines many women who have lipedema. Not all, but many. And I think Dercum's disease tissue is more stiff. So it can only hold so much fat in an area, and it becomes very painful. And so that, if it can't hold more fat, it's gotta go somewhere. And where does it go? It goes into the muscle. It goes into the liver, and it causes damage there. And that the fat becomes so fibrotic and stiff that people with Dercum's disease are at risk for metabolic syndrome, that prediabetes, but they also have a higher risk for developing diabetes. So this is a second way in which I think lipedema and Dercum's disease are different. So what microvessels are at risk in our body, are at greatest risk for damage? So when you stand, your blood pools in the bottom of your aorta, at the bottom of your thorax, so right under your navel, but also in your legs. And that's exactly where lipedema tissue forms, at least initially. A different way to explain this is when you're lying down, fluid equilibrates across your body. When you stand up, it forms a column and fluid settles down. And when fluid settles down, it can cause all of the fluid changes in the tissue we just talked about. So, as we all know, there's not just a leak. Everything in our body is highly, highly regulated. And I want to point out that in the microvasculature, there are smooth muscle cells, and you can see those little yellow bands that are all along that arteriole. And when the smooth muscle contracts, the size of the vessel decreases. When they relax, it expands. And at the entrance of each capillary, there's a little smooth muscle sphincter that can close it off. So, for example, when you get cold, your fingers get cold because your body moves blood into your core to keep you warm, you're contracting your vessels in your hands, but only your hands. You're not contracting them inside your body. You want to get warm inside your body. So your body is very smart. But there are also these little cells, which are so absolutely cool, called pericytes. And pericytes surround our capillaries and our venules, and they also regulate the size of our microvessels. And these pericytes can actually change into fat cells. They can change into muscle cells. They can regulate the growth of blood vessels, or they can inhibit the growth of blood vessels. They're very small, but they're very powerful. And there are different kinds of them as well. So where do you find your pericytes in your body? In that same place where fluid accumulates. That's the greatest concentration of pericytes because they're trying to protect the body against damage to those microvessels when that fluid column shifts downward when you stand. So now I want to talk about the sympathetic nervous system and how that interacts with smooth muscles and parasites. And the sympathetic nervous system is part of our autonomic nervous system, which can be very disrupted in Dercum's disease. And if you have a disrupted autonomic nervous system, you're going to disrupt your smooth muscle cells and your parasites. And the sympathetic nervous system innervates the heart, many of the organs in the body, but also those micro blood vessels. And the sympathetic nervous system secretes a number of neurotransmitters, including norepinephrine, which we also call noradrenaline, epinephrine, which we call adrenaline, serotonin, and dopamine, etc. But these neurotransmitters, especially norepinephrine, causes those parasites to contract. And it causes those smooth muscles to contract, reducing the capillary diameter. And this is a study that came out of Austria, and they took liposuction fat from women who had lipedema. They got rid of the fat, and they looked at all the cells that were left over. And in those cells that were left over, they found markers of parasites. And you can see those markers here. And what they concluded was that there is chronic capillary injury in lipedema. And so I think that's another way to confirm that we have microvascular disease in lipedema. But it may also signify that we have angiogenesis going on because, as I mentioned, those parasites regulate blood vessel growth. And those parasites can change into fat. So it may be also a marker that we have increased fat in lipedema. And Bruce Bonnell from Tulane is working on the same project in Dercum's disease. And this is, again, our fat tissue with the skin on top, and you can see the fat, and you can see our vessel leaking out into the tissue. Is that because we have parasite dysfunction? And that leakage is kind of like a bruise. And we know from published studies that we have capillary fragility in lipedema, or easy bruising in lipedema, right? I heard that yesterday over and over again. I have easy bruising. Here it is, a damage to the blood vessels. And why is that happening? So the sympathetic nervous system, this is my cartoon of it, feeds neurons onto the smooth muscle cells and the parasites. And you can see the capillary as the little red bar in there, and surrounding it is fat, and we call that perivascular adipose tissue, or PVAT. And when the sympathetic nervous system fires really quickly, the vessels contract. When it kind of relaxes and fires less often, then the vessels dilate. And it does that through both the parasites and the smooth muscle cells. And it's not as easy as I show. So there's a post-test on this when we're done. But you can see our smooth muscle cells, SMC, and you can see that there's the sympathetic nervous system feeding into it, and I've circled norepinephrine in red. So that binding causes all these reactions to occur, and this involves channels where electrolytes are flowing through. There's a lot of places where things could go wrong. There's a lot of genes that affect these processes, and I think, again, knowing the gene is going to help us pinpoint where the problem is and how we can fix it. And then on the right side of the diagram, you see the fat cell, right? You see all this stuff going on in the fat cell, and you see the red cell, that's the part of the capillary, and you see the blue cells, that's the smooth muscle cells. And do you see how they're all talking back and forth to each other? So your fat talks to your capillaries, and your fat talks to your smooth muscle cells. And if you have lipedema or Dercum's disease fat, is that conversation different? And it goes on. So you can regulate vessels in sections. So there's 3 different sections there that you can see. You could regulate just one section of that. And in addition, the flow of blood regulates the size of our microvessels. So if you've slowed down your flow because you have an inflamed vessel or a fibrotic vessel, that changes the caliber of the vessel in and of itself. And if you come to my clinic, what do we always talk about? Flow. I always say, you're congested, you're not flowing. We need to get you to flow again. And the reason is we need to improve the health of your vessels, because if your flow is slow, it is not good for the vessels, the microvessels. And I'm going to talk to you a little bit about compliance, a couple of compliance genes that are important in compliance. And these are not lipedema genes to my knowledge at all, but obviously there's a lot of work going on in this area. And the first gene is called TNXB for tenascin. And tenascin is an important part of our connective tissue matrix. And if you chop out that gene in male mice, they have not done it in female mice, and I'm on the phone, are you going to look at the female mice? And they said, yes, we think that's very important. I said, well, get on it. But if you knock it out, and that one gene in male mice, they get fat. So if you make the tissue more compliant, you can get fat. And I think that's kind of proof of concept of what's going on in lipedema and maybe even Dercum's disease. There's another gene called elastin, right? We have elastic tissue. Elastin is very important. It's in our blood vessels. It's on our skin. In this disorder called Williams syndrome, there's a huge deletion of a lot of genes, and one of those genes is elastin. And people with Williams syndrome, both men and women, develop tissue that looks exactly like lipedema. So again, this is just kind of driving home the point that there are many genes that can affect compliance. There may be a gene in lipedema and maybe even Dercum's disease that affects the compliance of the tissue. It may not be the gene, but it may be a gene that's important in how, for example, stage 3 lipedema develops. And when you get more fat tissue, you're at greater risk for developing venous disease. And when you develop venous disease, it's the #1 cause of development of secondary lymphedema. And now you see how the vicious cycle continues. So, and it's not just small vessels. I want to drive that point home. I mentioned that women with stage 3 lipedema are at greater risk for cardiovascular disease. In this study by Solnoki, they looked at the aorta, and the aortas were bigger. So when the heart pumps out blood, it's bigger, and when it stops pumping blood, it's still bigger than normal. But it only had a little bit of space to work. It didn't have that elasticity, so it became stiff. And if it becomes stiff, then you're at risk for developing cardiovascular disease. So it's not just a microvascular disorder. I believe it's also a macro or a big vessel disorder as well. We also know, and I'm not going to talk a lot about this, but in lipedema and Dercum's disease, we have dysfunctional lymphatics, and there are studies that prove that. So, 3 ways to increase fluid in tissue. Do we have microvessel leak, microvessel disease? Check. Do we have dysfunctional lymphatics? Check. Do we have an altered compliance? Check. We have not just one of these things, but in lipedema and maybe Dercum's disease, we have all 3. And I did mention about hypermobility in lipedema, and we did a study looking at the difference between lipedema and Dercum's disease. There was more women with hypermobility who had lipedema than the women with Dercum's disease. So again, we're looking in lipedema at more of a compliance issue, and in Dercum's disease at more of a stiff issue. And in the second paper published by the Allen and Hines group, so the Wold, Allen, and Hines paper, they said lipedema tissue offers abnormally poor resistance to the passage of fluid into the tissue from the blood. So lipedema tissue has poor resistance. It's not stiff, it's compliant. And they said that way back in 1951. So back to the sympathetic nervous system. So these are the 2 big globs are nerves that release neurotransmitters, and downstream that little turquoise circle, you could think of it as a muscle, or you could think of it as a blood vessel, or you could think of it as a lymphatic. And I'm going to talk a little bit about our work on amphetamines. And what amphetamines do is they increase the amount of neurotransmitters that are in that cleft there, in that space. And those neurotransmitters are usually recycled back up into the nerve, and amphetamines block that. So there's just a lot more neurotransmitters and a lot more information turning on that sympathetic nervous system when you take amphetamine. And if you incubate a lymphatic vessel with norepinephrine, which is a neurotransmitter from the sympathetic nervous system, those lymphatic vessels pump like crazy. So that's why I thought, maybe we should use amphetamines in our patients with lipedema and Dercum's disease to improve that lymphatic pumping. And we know that there are receptors So structures on the lymphatics that can touch the norepinephrine and stimulate contraction. And we know that we can improve flow in normal lymphatics. We can also improve flow in lymphedema, just not quite as well. So this is a study I did with Dr. Laila Abuzaid, who's graduating this year as an endocrine fellow and going to North Dakota. And we did a questionnaire study, and I have so many patients that I've used amphetamines in, and we asked 82 of them 82 questions. Can you believe that? We matched our questions too. And 98% of those participants were taking amphetamine at that time and had been taking them for, on average, over 2 years. And they took a variety of different amphetamines. Dextroamphetamine and Adderall were the most common, but they also took phentermine, amphetamine salts, some spansules, which I rarely give out, but sometimes insurance companies make me do it. And then one patient was on lisdexamphetamine. And 15% of them had tried a different amphetamine, mostly because of their insurance companies. And these are our baseline demographics. We had mostly lipedema participants, but a good number of Dercum's disease, and we had 2 ladies who had lymphedema. They were around 50 years of age, mostly female, mostly white, non-Hispanic, and they were an obese population, so their BMI was in the obese range. So we asked them about fatigue. What was your fatigue before you started amphetamine and after you started amphetamine? And if you look at the black dots, that represents Dercum's disease. If you look at the white dots, those represent lipedema. And you can see that the fatigue level in the patients with Dercum's disease is much higher than that in the participants with lipedema. So that's another way to distinguish between the two. And you can see after amphetamine, the amount of fatigue in Dercum's disease went significantly down, but not in lipedema. Their fatigue did not change, which was interesting. But when we asked them about their energy level increased in both populations significantly. We also asked them about leg heaviness. And you know, leg heaviness causes you to have more pain in your legs, and you don't want to do quite as much, and you want to just sit down and put your legs up to relieve that heaviness and pain, and leg heaviness improved significantly in both lipedema and Dercum's disease. Body pain reduced significantly in lipedema and Dercum's disease after amphetamine. And memory improved in lipedema and Dercum's disease. And you know, memory is a big deal in Dercum's disease. A lot of ladies come in and they're like, I can't remember things anymore. People come up to me and I know them well. You know, they're my uncle, but I couldn't think of their name. Or I can't find words, and my kids finish my sentences for me. So memory improved significantly in lipedema and Dercum's disease, and functionality improved. People function better and significantly better in lipedema and Dercum's disease. There were some side effects. The biggest side effect was insomnia, which happened in less than 20% of the people, but it was still significant. And women with lipedema became more irritable. And had more palpitations. And women with Dercum's disease got more headaches or migraines and more abdominal pain. And with Kieran Beltran, we published that people with Dercum's disease tend to have more abdominal pain than women with lipedema. And this is the biggest take-home message from this. In lipedema, almost 95% of them stated that amphetamine improved their life. If someone said, I have a pill for you and I'm going to improve 95% of the people in this room, would you believe me? Mm-mm. But look at that. And 90% stated it improved their lipedema. And in Dercum's disease, it wasn't quite high. 88% stated it improved their life, but 91% stated it improved their Dercum's disease. That's huge. But who wants to use amphetamines for the rest of their life? You know, not me. It's a controlled substance. You have to get a new script every month. You know, and it's an amphetamine. It's got a bad reputation. We need more supplements. We need more medications. We need more tools to replicate what amphetamines do, so that you can do for yourself what your doctors have to do every month, writing that controlled substance script. So even though this is amazing, I really like amphetamines, I wish I didn't have to use them. So in summary, we know that fluid accumulates in the fat tissue in lipedema and Dercum's disease. And in lipedema, we think there's a high compliance. It allows fat in, allows fluid in. And Dercum's disease is a little stiffer. We know that in both there's microvascular damage and inflammation. And we know that eventually, because of the fluid coming out of those capillaries and those venules, that we're overloading those lymphatic vessels and likely breaking down that glycocalyx and doing additional damage. And we're enlarging that interstitial organ. We're filling it with fluid. We're filling it with fibrosis. And that's causing additional lymphatic dysfunction. We know there's broken vessels in the tissue, so our goal should be to improve those vessels. And gravity is not your friend in lipedema. And when we see lipedema combined with Dercum's disease, it's always in the gravity areas that we see the lipedema. Something else, though, is going on in the trunk in Dercum's disease, and we need to figure that out. And I think I've shown you that amphetamines improve the quality of life and fluid handling, but we need larger trials. So we need a randomized placebo-controlled trial to actually prove that, and I think encourage an industry and other scientists to develop other molecules that can do the same thing without the side effects, especially in lipedema. So here's our treatment targets. We need to improve that glycocalyx. We need to improve the parasites so that they work to their best ability. We need to improve the smooth muscle and keep them healthy. We need to improve the integrity of the walls of our vessels. We need to stop the fluid leak. And we need to improve lymphatic pumping to get the fluid out of the tissue. And we need to improve the health and decrease the amount of fat tissue that's surrounding the vessels and talking to the vessels, the smooth muscles, and the parasites. So the therapeutic targets in my mind right now are the vasoconstriction pathways, the smooth muscles, the parasites, the endothelial cells, the microvessels, and the glycocalyx. And we know that bioflavonoids improve the glycocalyx. And we also know that for improving lymphatic function, in addition to amphetamines, we have butcher's broom, we have quercetin, but it's just not enough. We really need to find the gene, and you're going to hear a little bit about genetic work from Jan Clementidis today. And there's also other groups that are being supported by the Lipedema Foundation to find the gene. It's a big drive, and I really want to make sure that by the time I retire that we know the gene, and then I can just sit back and watch wonder happen. So thank you very much. I want to thank my treat team, especially Sarah Al-Gadban, Chris Ussery, Yunira Sanchez, Rita Wadia, and Marisol, and also a new fellow that's working with me, Leopoldo Cobos. I want to also thank the Lipedema Foundation, the Rhode Island Dercum Society, and also the FDRS for their support. Thank you very much. Oh, sure.